Thanks everybody for joining. This is Carol from the STS. This is our STS Adult Cardiac Surgery National Quality Improvement Series on decreasing vent times. We have a special presentation today from one of the hospitals that's close to us here at STS in Chicago, North Shore University Health Systems in Evanston, Illinois. It's Evanston Hospital. And we will get started there with them in just a few seconds, but first I have a couple STS updates. Important dates today is the Quality Improvement Series. Next Tuesday starts AQO. The platform is already open. I'll get to that in a second. Next Thursday, September 28th is AQO ACSD all day. If you haven't registered yet, it's still open to register. We're not going to close registration until December, just to give folks the opportunity. If you're not able to register live now due to financial reasons, we're leaving it open a couple extra weeks, so you can still get all the content. The content from the live presentations that are happening on September 28th will all be recorded, and then we'll also have our Hot Topics webinar early in December, which is only available to those who register for AQO. So if you haven't registered yet, please do so. If you have registered, AQO is open to start watching the on-demand sessions. Email with the login information went out yesterday. October 4th, we have a monthly webinar on our beta blocker project. If you're able to join, please do so. It will be recorded, but this is an important topic. We're asking for your help in national quality improvement to better understand beta blockers, and we'll get more into it on October 4th. That will also be recorded and posted. On October 18th is a quality series improvement webinar at 2 p.m. Central. I expect that we'll have Harvest 3 results out by then. I did a preliminary look, and it does look like we're all working together very nicely, and I can see some decreases. So I'm happy to share that with you on October 18th once we have our Harvest 3 results out. November 1st is the monthly webinar, and we'll be preparing for Harvest Close unless Melinda wants to take that over with education, because Harvest closes on November 10th. That will be OR dates through September 30th, 2023. The opt-out for that is November 14th. Please be sure to get your data in early, cleaned up, and ready to go. We will go over the reports available on the IQVIA platform to ensure that the cleanliness of your data on the 1st, but I hope that you have your data in prior to that. November 15th is an adult cardiac the quality improvement series, and I don't have a topic yet, more to come. Like I said, AQO platform is now open. Harvest 3 data is an analysis. Oh, and one other thing I need to talk to you all about, the still in hospital patients. So there's a box on your chart, on your data collection form, where you can mark that the patients are still in hospital, and then you don't have to fill in the post-operative information, or the you fill in the post-operative information, but you don't fill in the discharge information. You're not supposed to fill in the post-operative information completely until after the patient is discharged, just to make sure you have complete charting. When we went back and looked, and the STS analytics team noticed that there are still quite a few patients who have been marked still in hospital for a number of harvests. And it's unlikely that those patients are actually still in the hospital. So if you use this field, or if you used it in the past, please make sure to go and clean up those patients, finish their charting, and resubmit to the data warehouse so we have them in there for analysis. And now it's time for the show. We have North Shore University Health System from Evanston Hospital, they're going to present for us today on the STS ACSD data drives quality improvement and furthers research decreasing intubation time for cardiovascular surgery. Hannah Whitney, who many of you know from joining our webinars, she's been a data manager for quite a while. She's seasoned with the STS database, and work closely with her on data abstraction techniques and cleaning up data and using data for quality. She reached out and was very proud of her hospital for the project that they did on this and wanted to share it with you all. Hannah is a CV surgery quality manager, background in nursing, very strong background in cardiac and ICU nursing and in quality. So Hannah, please take it away and just let me know when you want me to switch slides. And first of all, thank you to you and your team for offering to present this to us today and sharing this with us. We look forward to learning from you all.
Thank you, Carol. You can go to the next slide, please. Which was Dr. Russell was our chief cardiovascular surgeon, actually got called in the OR. He was scheduled to be here. So I am going to take over for him. Next slide, please, Carol. North Shore actually has 5 hospitals, 2 of which do cardiovascular surgery now. We have 1 team that covers both hospitals with 4 cardiac surgeons, 2 APNs, 5 PAs, and 6 perfusionists. We're going to be looking only at Evanston Hospital patients today, but we share projects, we share protocols, but this particular data project was just with Evanston. Now, last year, our volume was a little bit lower than our normal pre-COVID, and it's climbing back up. We do a lot of, these numbers don't include our TVTs, or LVADs, or ECMO patients either. So next slide. All of us here actually use and very actively participate with the STS database collection. We spend a lot of time and resources getting this data. And North Shore decided that it was imperative that we use it for not just for our outcomes report, quarterly reports, star ratings and stuff, but to use it to actually drive our everyday care. And some of those projects that we use the STS data from are our quarterly isolated CABs, which is pre-submission data, our quarterly M&M, where all the cases that are outliers in the STS inputted into the STS database are actually reviewed by the actual surgeons with the team. And we use our STS risk-adjusted star rating dashboard. This is some of the quality issues we've used. We use our the STS data to check on our MVRR appropriateness audits that we do annually. We monitor our aortic dissections, and we use it routinely to identify EMR and documentation issues so that we can correct them in a timely manner, and for research. And this is the big part of what we're going to show today. Next slide. And to go over this process of how we enabled our ICU teams to get these patients expeditedly extubated, I'd like to introduce you to Valerie Reed. She's our CV surgery APN. Val?
Thank you, Hannah. And thank you for that beautiful segue. Just to begin, I wanted to start off with giving you a brief overview so you know how our patients interact with different teams along the period from OR to extubation. So the patient has their surgery in the operating room. They're brought up from the OR by anesthesia, the cardiac surgery PA, and any other OR assistants and techs, and depending on whether or not they have any mechanical circulatory support, it's plus or minus if perfusion comes with them. That group of people meets with the ICU, APP, the ICU nurse, and respiratory for a handoff at the bedside in the ICU. And after handoff is given, anesthesia leaves the room, goes back down to the OR. The cardiac surgery team at Evanston stays primary in the ICU, and the critical care team is utilized as a consultant service for things like ventilator weaning and hyperglycemia management and other things like that. So moving on to the next slide. There are 2 tools that I would say we use to help get more expedient extubation times. The first of which is our handoff tool that was developed by the ICU in conjunction with CV surgery. There are 3 parts to this that are important to highlight. The first is the participants. We have the cardiac surgery APP there, the anesthesia, either CRNA, resident, or attending. Critical care APP or attending is there, the ICU-RN, like I said, plus or minus perfusion, and the respiratory therapist. So the second part of handoff is the history. So we go through the patient's medical history, anything that's pertinent, the surgical history, what happened in the OR, what the heart function looked like, if we're worried about any arrhythmias, bleeding, anything like that. That is reported on by the cardiac surgery team. Next, that moves along to anesthesia, who talks about the history of vitals in the OR, if the pulmonary artery pressures were high, things that we're concerned about, what the airway was like, if it's easy, if we are worried about leak tests or anything like that, and any drips or significant labs that the patient had an issue with in the operating room. Next slide. All right, the final part is the plan. So handoff is handed back to cardiac surgery, and the patient we identify it as plan A or plan B. So if you note the little asterisk down at the bottom, plan A is our fast track patient. Plan B means that there was something going on in the operating room where a fast track extubation might not be beneficial for the patient. We go over the plan. So is this a plan A patient? What is the extubation time? Generally for us, that's 4 to 6 hours after coming up to the ICU room. We go over any plans for bleeding, plans for pain medication, and identify a patient to go to with concerns. Then critical care takes over and talks about the plan for weaning ventilator settings if they're not on minimal vent support to begin with. And we identify the sedation plan for weaning. And this is really important because everyone is at the bedside, everyone has a chance to ask questions, voice concerns, and everyone knows the plan. We have a really strong group of nurses, and in having everyone there, it puts everyone on the same page, and it's identified if, one of our surgeons was concerned about inotropes or heart function, all of that is discussed in the beginning. And it's really clear if we're weaning drips first or when we're going to start weaning the ventilator. So really just having everyone on the same page to begin with and having a clear plan identified. Next slide, please. So this is the second tool that we utilize, and this was developed by the ICU nurses for a spontaneous awakening trial and a spontaneous breathing trial. So really when you're looking into extubating, you're looking to make sure that the patient is physiologically stable to start the weaning process. And then you have to deal with how they are waking up. Is there blood pressure going up? Are they restless and putting themselves at risk for pulling out tubes and drains? So if you take a look at the slide on the screen, you can see that it makes mention of ICP and some other issues that don't deal with cardiac surgery patients. So this is actually developed for all of our patients in the ICU and extubating them at an expedient level and making sure that they all are evaluated for extubation at an appropriate time. So you'll see sort of a cyclic nature to this workflow, and that's what it's meant to be. So initially is the safety screen for whether or not the patient is safe to proceed with an awakening trial. So this for a cardiac surgery patient means they're not bleeding, that they're not having escalating doses of vasopressors, that they're not on extremely high ventilator settings to begin with, and that there's no reason to anticipate they would be going back to the OR. So if all of those are met, then you can move on, or if the patient is not experiencing any of those, you can move on to actually performing the spontaneous awakening trial. This has to do with how the patient is waking up. And in cardiac surgery patients, the goal is to be at this point within an hour after the patient arrives to the room. So at this point, the nurse would stop the propofol. The majority of our patients at Evanston, I'd say just about 100% of them, come up with propofol infusing. And after everything gets settled, this is usually the sedation of choice that's turned off. And the patient is monitored for RAS. So does anyone need RAS explained? Or that's what we use for agitation. So making sure that the patient is calm, that they're not incredibly tachypnic, they're not desaturating. So basically making sure that they are tolerating being awake and having lightened sedation after the procedure. If they're doing well with this, then we move on to the next safety screen, which is, are they safe to have a spontaneous breathing trial? The two major markers for this are just vent settings. If they're requiring too much FiO2 or a PEEP above 10, then we would readdress this with the providers. You can go to the next slide. All right, so assuming that they are appropriate for the SBT safety screen, we move down to the actual SBT trial, and the nurse works with respiratory therapy. They are able to put the patient on a spontaneous breathing trial, monitor their respiratory rate, looking for any arrhythmias, signs of distress, and from there, if the patient tolerates it for about 30 minutes, can independently ask respiratory therapy to obtain weaning parameters and usually a CPAP EBG. After all of those data points have been gathered, there will be a discussion between the ICU nurse and the provider. Usually it's the ICU provider about if extubation is warranted or appropriate, and from there you will extubate or not. So that is kind of the perfect, in a perfect world, this is what happens type of flow for this workflow, but everybody knows that that doesn't always happen. And so any of the times that you reach a no in the flow of the pathway, there is always a reassess. So if the patient is tachypnic, you treat that and then reassess, do we put them back on full settings? Is it just treating their pain? So it really just kind of works in a circle. And one of the things, you know, that Hannah had mentioned is that our extubation time started going up as we were finding turnover with our nurses and having people a little less experienced with that. And I know that that's an issue that's going on all over the country and not just here at Evanston. So one of the things that is really important about this nurse-driven awakening trial and breathing trial workflow is that it really helps in assistance of newer nurses as well as experienced nurses, because it really highlights what you're looking for as far as each step of the pathway. If your patient's too agitated, if your patient is breathing too fast. And, you know, in the case of a newer nurse, they say, oh, I'm looking for this, I'm going to go talk to my provider. And so it really works with a newer person that's less experienced. Whereas with a more experienced nurse, it allows a little bit more autonomy. So if they find that the respiratory rate is high, you can troubleshoot that. Are they having pain? Are they not able to take a deep breath because of that? And give some PRN pain medication and reassess and sort of continue on as, you know, the PRN pain medication allows, and really sort of allows for both of those nurse experience levels to work through things and deliver good care to the patient. So that is what we have. That is what we use, and it has been working very well for us. Like Hannah said, we were instituting, you know, early extubation protocol in 2014, and you know, this was always sort of known, but was developed into an actual workflow and protocol over the last few years, and actually have it written down, which was when we started experiencing a little bit more of that turnover that everyone's seeing, and is proving to help move things back up where we want. So I think that's it for me. So next slide, we'll be handing it over to Dr. Steve Greenberg, who I have worked with for just about as long as I've been in the ICU. He is the anesthesia chair of research and education and a good friend. So he's going to talk about neuromuscular blockade now.
Thank you, Valerie, and I would echo what you said. I think one thing about quality and patient safety is it's about relationships that you have within your hospital system. And I'm proud to say that we have a fantastic relationship with our perioperative providers. And I want to thank Hannah and Dr. Russell and Valerie for their collaboration in this project and several others. So thank you again, and fabulous discussion in the previous slides. Today, I'm going to talk a little bit about something near and dear to my heart that we've collaborated with the Department and Division of Cardiac Surgery, and that is residual neuromuscular blockade. Can you advance the slide? There we go. So first of all, talk about mechanisms of neuromuscular blockers. And in the red, you can see there are two types of neuromuscular blockers. One is a depolarizing neuromuscular blocker, which actually binds to the acetylcholine receptors. On the bottom hand of the screen, there's a muscle, and on the top, there's a neuron. And those little round circles coming towards the receptor are acetylcholine molecules. And the depolarizing muscle relaxants bind to those acetylcholine receptors and cause fasciculations and then flaccid paralysis. Whereas the non-depolarizing muscle relaxants actually bind to the acetylcholine esterase receptors competitively and therefore block the ability of acetylcholine to bind to those receptors. Next part of the slide. I don't think I can advance. There are three common types of muscle relaxants we use in heart surgery. On the right side of the screen, you'll see succinylcholine, which is the only real depolarizing muscle relaxant we have. And the indications for using succinylcholine in heart surgery are patients who have full stomachs to prevent pulmonary aspiration because the onset of action of the drug is extraordinarily fast. We do not use it for maintenance of muscle relaxation during surgery. On the very left side of the screen, you'll see rocuronium, which is the most common non-depolarizing muscle relaxant that we use in the perioperative space. And then just to the right box is cisatracurium. We use that in special circumstances where patients have liver or kidney dysfunction as the drug gets metabolized in the blood by esterases. Next slide. So the question is, why do we use muscle relaxants intraoperatively, and particularly during cardiac surgery? Well, the obvious thing is to facilitate smooth endotracheal intubation, but also may optimize surgical operating conditions and, of course, prevent movement during high stimulation periods of surgery. And of course, upon transport to the ICU, where if the patient was moving significantly, they could be a danger to themselves and others, and particularly variations in their hemodynamics. Next slide. So during most surgeries on the left side of the screen, we actually reverse neuromuscular blockers with antidotes. And this has been shown throughout the literature to lower residual neuromuscular blockade. However, in cardiac surgery, we typically do not reverse neuromuscular blockade. And of course, the last several decades, we've allowed the body to metabolize the neuromuscular blocker on its own. And this may lend itself to a higher risk of residual neuromuscular blockade. Next slide. So the question is, what is residual neuromuscular blockade? The current definition in the literature is a train of 4 of less than 0.9. Now you may say, what is a train of 4? Well, the train of 4 is elicited by a quantitative neuromuscular monitor, either using EMG or accelerometry, and it's the amplitude of a fourth twitch divided by that of the first twitch. So we usually apply these devices to the hand or the face or a facial nerve, and we look at 4 stimulated twitches, and we compare the first one to the fourth one. And a decreasing train of 4 ratio indicates a greater degree of paralysis. So you can see on the right side of your screen, the optimal train of 4 for full recovery is equal to or greater than 0.9. Next slide. And the incidence up to in non-cardiac surgical patients may be up to 65% of patients with residual neuromuscular weakness. And this depends on a variety of factors, including the study design, the definition, method of measurement. You can read the rest there. There's a lot of variables, but the incidence is amazingly high and actually really hasn't budged in the last decade and a half. Next slide. You may think, okay, residual neuromuscular blockade, what does that really mean to our patients? Well, there have been several studies. In fact, several of the studies that look at the data, actually, we performed ourselves over the last 2 decades at North Shore. And we looked at the train of 4 of less than 0.9. What we found in a variety of surgical specialties that there's an increased risk of postoperative hypoxemia or low oxygen saturations, an increase in airway obstruction during postoperative acute care room or transport, higher risk of critical respiratory events in the PACU, signs and symptoms of profound muscle weakness that may look at like swallowing difficulties, double vision, drooping of the eye, delays in meeting PACU discharge, prolonged postoperative ventilator weaning and increased intubation times, and of course, increased postoperative pulmonary complications. And a recent observational prospective trial among 9 countries and over 700 patients looked at the relationship from a variety of characteristics and postoperative pulmonary complications. And what they found was that when neuromuscular blockade was used outside of intubation in heart surgery patients, there was a 2-time increased risk of pulmonary complications. So there may actually be that association between residual neuromuscular blockade and pulmonary complications. Next slide. So what are some methods to reduce the risk of residual neuromuscular blockade? Well, first, we can use shorter-acting neuromuscular blocking agents. And actually, at our institution, we compared longer-acting to shorter-acting neuromuscular blockers in the heart surgery population several years ago and found that we should be using shorter-acting muscle relaxants as that reduces the time on the ventilator, length of stay, so on and so forth. But we also should be using quantitative monitoring. Quantitative monitoring gives us that train of 4 ratio so that we can make sure that the muscle receptors have actually regained their function to 0.9 or greater. We know that clinical tests like raising your head or squeezing people's hands is far below the train of 4 of 0.9. So they should not be used if we want to ensure that patients do not have residual neuromuscular blockade. Now, the third thing is that we can administer neuromuscular blocking reversal drugs. And there are 2 common ones known and given in the perioperative space. Sugammadex is more effective with moderate or deep blockade versus neostigmine, which is acetylcholinesterase, which is primarily used for shallow blocks of neuromuscular blockade. Next slide. Talk a little bit more about these 2 primary choices of the reversal or antidote agents to neuromuscular blockers. Sugammadex is a modified cyclodextrin that reverses neuromuscular blockers by encapsulating primary aminosteroidal muscle relaxants. The advantages are that it has a shorter timed reversal than its counterpart, neostigmine. It's more effective with deep forms of block. So if you use a lot of muscle relaxant in the operating room, it's more effective than neostigmine. And it might cause less high heart rate and high blood pressure in the perioperative space. But there are disadvantages. It may cost more money. It can only be used in the setting of drugs that are aminosteroids, such as rocuronium or vecuronium. and it has a 10-time increased risk of anaphylaxis or bronchospasm when comparing it to its counterpart neostigmine. Still, its incidence of anaphylaxis can be about 0.02%, so pretty low globally. Neostigmine is acetylcholinesterase inhibitor. Therefore, again, it increases the amount of acetylcholine at the neuromuscular junction. And it's relatively cheap or cost-friendly. Lately, it's in some states, it's been hard to get or there's been shortages. But it also has a very low allergenicity rate. And you have to use it with an antimuscarinic, which can raise not only the blood pressure, but the heart rate as well. Next slide. So the 2023 American Society of Anesthesiologists practice guidelines for monitoring and antagonism of neuromuscular blockade just came out this year. And I want to point out and focus on 4 major statements they made in this very important document in anesthesiology in 2023. First, we should be using quantitative neuromuscular monitoring to confirm recovery of neuromuscular blockade. Sugammadex is recommended for deep, moderate, and even shallow levels of neuromuscular blockade induced by those immunosteroids such as rocuronium or vecuronium. Neostigmine is a reasonable alternative for minimal blockade when minimal blockade is observed. And patients with adequate spontaneous recovery of a train of 4 of greater than 0.9 with quantitative monitoring do not require pharmacologic antidote or antagonism of neuromuscular blockade. Next slide. So why did we perform the current retrospective study that my colleague and research assistant, Noah Ben-Isvi, is going to talk to you more about in the next 5 minutes? Well, first, recent data shows in the cardiac surgical literature that there's advantages to using neuromuscular blocker reversals, i.e. shorter time to extubation and a reduction in ICU and hospital length of stay. There really are no current studies to address the association between neuromuscular blocker reversal use, such as Sugammadex, and meeting the STS extubation criteria of less than 6 hours from end of surgery. So, our hypothesis was that those STS-defined urgent and elective cardiac surgical patients who received Sugammadex versus those that did not were more likely to be extubated within the 6 hours of the end of surgery. Next slide. And so now Noah Ben-Isvi, who is our research assistant in the Department of Anesthesiology, is going to talk about the recently published article that our group, along with Dr. Russell, Hannah, and others published, titled A Retrospective Pilot Comparison Trial Investigating Clinical Outcomes in Cardiac Surgical Patients Who Received Sugammadex Reversal during 2018 to 2021. Noah, go ahead.
Yeah, thanks for that introduction, Dr. Greenberg. So this study carried out at North Shore is a retrospective analysis of cardiac surgery patients who received Sugammadex versus those that did not receive reversal during the 2018 to 2021 time period. So next slide, please. As Dr. Greenberg mentioned, during surgery, every patient receives a neuromuscular blocking agent that reduces movement during surgery, like rocuronium. In most surgeries, the patient will then receive a drug at the end of the surgery that reduces the effects of the neuromuscular blocking agent. However, in the cardiac surgery population, only some patients receive the reversal agent due to fear of bleeding, arrhythmias, and respiratory distress, potentially leading to reintubation. The research problem that we were trying to better understand in this study is whether administering Sugammadex, a reversal agent, to cardiac surgery patients leads to improved clinical outcomes compared to not administering any reversal agent. Our retrospective analysis included elective and urgent cardiac surgery patients to answer the question of whether Sugammadex reversal increases the number of patients meeting the STS criteria of extubation within 6 hours. Next slide, please. First, we utilized the STS database to collect patient information such as demographic information, case status, extubation times, surgery duration, cardiopulmonary bypass duration, number of intraoperative blood products, ICU length of stay, and hospital length of stay. We then defined extubation criteria according to STS criteria, where extubation within 6 hours of OR exit time is favorable, while extubation 6 to 24 hours, meaning later extubation for fast track extubation patients, would be a less favorable outcome. Other data points that were not within the STS data that we were interested in, like Sugammadex administration, were manually extracted from EPIC. The surgical procedures included in this analysis were expanded beyond just coronary artery bypass graft surgeries. Our analysis included aortic valve replacement plus coronary artery bypass alone, mitral valve repair, mitral valve replace, and mitral valve replacement plus coronary artery bypass. So this data was collected on 358 patients. Then we utilized a 1-to-5 propensity score matching to match patients in the no reversal group with patients in the reversal group based on similar demographic characteristics. A total of 180 patients were included in this propensity score matching analysis. Next slide, please. After using this data collection and analysis approach, we found a statistically significant increase in the percentage of patients extubated in less than 6 hours in the Sugammadex group. This suggests that Sugammadex reversal could in fact lead to an increase in the number of patients undergoing cardiac surgery on cardiopulmonary bypass beating the STS benchmark. All additional outcomes in the study beyond the extubation time were not found to be statistically significant. Next slide, please. Based on this retrospective analysis, we are currently conducting a prospective randomized controlled trial comparing clinical outcomes of cardiac surgery patients receiving Sugammadex versus placebo. The study drug is administered 15 minutes after arrival to the ICU, and residual neuromuscular blockade is assessed through a quantitative monitoring system. The quantitative monitor provides information on train of 4 count and ratio to better understand the effects of Sugammadex during the post-operative recovery period leading up to extubation. In the prospective study, the train of 4 ratio must be greater than or equal to 0.9 before the patients are extubated. As in the retrospective study, the primary endpoint of this prospective study is the number of patients meeting the STS criteria of extubation within 6 hours compared between the placebo and Sugammadex groups. Additionally, we're also looking at hospital length of stay, ICU length of stay, and nurse perception of quality of recovery. Next slide, please.
Wow. This is Carol from the STS. That was a fabulous presentation. Are there more slides, or is this the time for questions and answers for the whole presentation?
I did include, this is Hannah, I did include a couple of slides down if anybody's interested in what it looks like to actually do quantitative neuromuscular monitoring, because to be honest, I didn't know. So I asked Dr. Greenberg to provide it in case anybody wanted to, because I know a lot of people don't see this. So I did add that.
Thank you, Hannah. This is great. And thank you to your team. Thank you, Dr. Greenberg. Thank you, Noah. Thank you, Valerie, for presenting. Just a phenomenal presentation and study that you all have performed using the STS data, improving patients' extubation time, and your continued success in your ongoing prospective trial. Thank you so much for presenting and finding our group worthy of sharing that information. I feel that it will be helpful to many sites, both sharing with their surgeons and anesthesiologists and their ICU nursing team to take some key points away from what you all have done to improve the care at their hospitals as well. So thanks for letting us all be part of your team and your success. I don't even know what to say, because that was just, I wasn't expecting that. Just thank you. That was a great presentation.
We're open to taking any questions too, Carol.
Yeah, I do have a couple questions from Beth. So first, Vicky is asking if the slides will be posted, and yes, the slides will be posted. Please give me a couple weeks, because we have AQO happening. This week is the on demand, and next week is the live presentation. I hope that our marketing will be able to get it up by next week. I'll send these over to them as soon as possible. What will be missing are North Shore's slides with their own site data from the presentation. So I'll have to cut that part out just because we don't want to share their information on YouTube where it's open to the public. The next question is from Beth Keneally. Does QC do these dashboards for you? I guess the question is who does your dashboards for you?
I do.
Hannah.
I do. I download the data from, well, we used to use Lumedix, which from Lumedix database, you could download any piece of data that we put in for the STS. So anything. And I took classes on how to build queries, and we used it a lot. So, but when we went to Q-centric, one of the questions I asked them was, can we get our data? I mean, we spend a lot of money to put it in there. I want to be able to get it back. And they're really doing a lot of progress. So a lot of the data is available, not all of it. So I'm hoping and trying to encourage them to increase what they make available, but I download all the data and then I put it into that format. It is a little time consuming, but it makes it a quick look, and really my job, I see my job as the quality managers to make the team I work with make their job easier. So they don't have to click. I actually went on IQVIA and clicked through their screens. There was 100 clicks to get even a quarter of that data. So, and that's just one hospital. We have 2 hospitals. So I try to make it as simple as possible and people can look for what they want.
Great, thank you. And to go on, to tag along to that question is, they would love to have a copy of the dashboard, or I guess dashboard template, if you're willing to share that.
I can get, the dashboard actually is the CAB dashboard, because it's the pre-submitted data is actually, I built a dashboard that calculates everything. So I just put the total number at the top and it calculates all the percentages I put it in. And then calculates for North Shore, because that's 2 hospitals together. Most hospitals don't necessarily do a dashboard for more than one site. So I'm certainly willing to send the blank copy with even the calculations in there if they want it, but at least to know the format in which it's done.
Yeah, and if you're open, Hannah, to folks reaching out to me, and then I can pass their email along to you.
Yes, of course.
Okay. Yeah, if you want to reach out to me at ccrone@sts.org, I'll put you in contact with Hannah, and then you can have that info. You could.
And I did send you the protocols.
Yeah, I have those, and I'll post those along with the PowerPoint
Okay.
slide. I have to send it all over to marketing. Yes, and we'll post the slides, Vicky. And then let's see, a couple questions here. Copy of the ICU driven spontaneous awakening trial and spontaneous breathing trial slides. We'll post those. Is that also what you sent me with the PDFs?
Yes.
Okay, thank you. I'll post those as well with the slides. And then who assesses the quantitative monitoring? And when is it done? Is it done in the OR before they are headed up to ICU, or is it done once they're in ICU after that hour of getting that patient settled?
Steve, can you take that?
Yes. So,
Thanks.
optimally, actually, we're slowly, as anesthesia providers, we are trying to transition to a quantitative monitoring method. This is relatively new, to be honest with you. The classic way of checking whether patients have recovered from neuromuscular blockade is actually a qualitative perspective, looking at movement of the hand upon stimulation and deciding for yourself, is that recovery adequate? We know that that's not good enough. So there are both EMG devices and accelerometry devices that you hook up to the hand. It's actually a sticker, and the ones that are shown on the screen here are devices that are a little old now. We actually have better devices that have better adhesives on the ulnar nerve distribution. But we actually hook these up right after intubation, and you can tuck the arms and keep the device on throughout the whole entire procedure. For our actual study itself, we're primarily using quantitative monitoring at the end of the procedure and into the ICU. Really, we want to make sure that patients have fully recovered before we extubate them. And I would say most of the times, being an intensive care doctor, patients probably have some subtlety of residual neuromuscular blockade when we extubate them in the ICU. We just don't detect it because we're happy the breathing tube's out and that they're breathing on their own, but they might have some subtlety in terms of swallowing or eating or they might have some droopiness in their eyes or have difficulty seeing, things that they may not even report, frankly, in the ICU because there's so many other things going on. But this monitor will really help us actually delineate full recovery from muscle blockade. And so that's what differentiates our prospective trial from other ones out there, where they didn't use any type of monitoring to decide after reversal or not whether they should take the breathing tube out. One of the criteria for this investigation is meeting that 0.9 or greater ratio by this quantitative monitor, which is in the left lower hand screen of the slide set. The version that we're using right now is about 2 or 3 versions better than the picture in the left lower screen. There's just one sticker. It looks very complicated, but there really is just one sticker that goes from the thumb onto the wrist. And there's a long cable, so you can tuck the arm and you can put this monitor and put it right on an IV pole, so it's very portable. And the data gets captured within the monitor itself. Did I answer that question?
You sure did. You gave a great answer, very thorough. Who typically performs the neuromuscular monitor?
An anesthesia professional.
Okay.
So, however, in the ICU, it can be anybody. It can be, usually it's the ICU nurse. And we've had a really good relationship. Our ICU nurses, Valerie used to be an ICU nurse, but they would actually perform qualitative neuromuscular monitoring. And we really want to transition to this quantitative approach because it's just more sensitive and specific to eliminate residual neuromuscular blockade in all patients.
Yeah, that's great. Make sure the patient is truly awake in order to handle that extubation appropriately and breathing and swallowing, and there's no residual. That's wonderful. A question from Judy is, what type of dose of Sugamax? How am I saying that right?
Sugamax.
I heard you say it 5 times and I was practicing it and I
twister.
totally lost it. Sugamax.
Sure.
I'm just gonna call it Shugs.
Yep. Nope, you can call it anything you want. So the dose is based on actual body weight, typically, and there are different doses based on the twitch count that you elicit. So for instance, greater depth of neuromuscular blockade requires higher doses, and it's on a milligram per kilogram dosing. So common dose that we use is 2 milligrams per kilogram, which would mean that patients have a significant amount of the neuromuscular blockade that's worn off, but not completely worn off. If there are deeper forms of blockade, then we would have to use a 4 milligram per kilogram or even an 8 milligram per kilogram dose. So that, for this conversation, that's probably all you really have to know. Go ahead.
That's perfect. Thank you. Thank you, Dr. Greenberg. That's more than enough of an answer. I think, Judy, if you have any questions on that, feel free to reach out and I can put you in contact with Dr. Greenberg and
Sure.
the North Shore team. Thank you. Want to see the name of the article again. So I'll pull that up. If I get there quick enough, sorry. There it is. It's a retrospective pilot comparison trial investigating clinical outcomes in cardiac surgical patients who received Sugamax reversal during 2018 to 2021. And you could take a screenshot of that if you wanted to look it up. Well, but these will also be posted. And I don't know if this is open access article or not, but you'll have the information if your medical library is able to pull it for you at your hospital.
It's not open because I tried to get it and I couldn't. So I had to have my hospital library get it for me.
Okay. Yeah, I'm sure I can probably get it. I just don't want to distribute it.
Right.
not
We
open access.
we can't. So
Okay.
I looked into that.
Okay, thank you. And then I don't have any more questions right now for your team. I'm sure that everybody is very grateful for your presentation. I was blown away by it. Thank you so much. Sometimes I feel like a podcast host, but and just saying those things, but truly from a nursing, from an ICU nursing background, from quality improvement background, this hit home for me, and this was a really great presentation. Thank you so much for taking time to share it with us. And I do have another question on our quality improvement project. So Christina's asking, are we going to have more presentations on the quality improvement side for event times, or are we moving to beta blockers? The beta blocker project is something that will just be a one-time webinar. Some more information to come on October 4th for that. We are still focusing our national quality improvement project on vent times for the time being. Our next project after vent times will be reducing blood usage, intra-op and post-operative blood usage. That'll be coming in 2024. But for the meantime, we are still focusing on vent times. And if anybody has a story from their hospital that they would like to share, any type of studies that you've done or quality improvement projects that you've done, please reach out to me, and I'm happy to get you in the schedule. Our quality improvement webinar for October, we will be, I think that's October 18th. We will be looking at, let's see, October 18th, we will be looking at, I plan that Harvest 3 data will be available. That's OR dates through June 30th of 2023. I plan that we will be looking at the vent times up through June 30th and seeing how we're doing. Preliminary look at that when I just pulled some basic data. Preliminary looks are that you can definitely see a decrease. Now, if it's meaningful or not, I don't know, but it looks like it could be. So more to come on that. And I'm going to ask our analytics team to do a little bit of analysis for us prior to that presentation. So still focusing on vent times, and let me see if we have anything for your just a lot of thank yous coming in. And I think that's what we have. So AQO, this question is on AQO. Will the on-demand AQO videos be available next week, and how much time after AQO? We usually try to leave up the access for a year, and we usually shut it down just prior to the next AQO, so that will still be available to you. Hannah made a great point about the number of clicks to get a quick report out of IQVIA. Is there any more thought to the executive summary? We will have an executive summary coming out, hopefully by the end of 2023. That will be, we reviewed this in a previous webinar. When we have it more finalized, right now IQVIA is building it. And when we get closer to the release date, I'll do a webinar regarding the executive summary. And Lisa says, great presentation. Bonnie agrees. And if we don't have any, sincerely grateful for you sharing your QI project. If we don't have any other questions, I think we're ending pretty close to on time. So thanks everybody for joining. Thanks again, Hannah, Noah, Dr. Greenberg, and Valerie for joining and presenting with us. Greatly appreciated. Welcome back anytime. We would love to hear an update on your prospective trial when it's available. Feel free to let me know on that, Hannah, or if you're really retired by that time, anybody on your team can reach out to me.
I will let them know, definitely.
Hannah tried to retire, but they got her back. So.
Thank you, everyone. It was a pleasure.
Yeah, thanks again, and have a great rest of the day. Thank you.